Good afternoon, everyone. My name is Annie Young. I'm the Executive Director of the New Mexico Medical Society, and it's my pleasure to welcome you all to, excuse me. It's my pleasure to welcome you all to the second of a two-part series on the Elizabeth Whitefield End of Life Options Act. This series is accredited for CME, CE, through Rehoboth McKinley Christian Healthcare Services in Gallup, New Mexico. To claim the CE credit, we ask that you put your name and email in the chat box. Each of the series parts is accredited for 1 hour for a 2-hour total. Sabrina Figueroa, the CME coordinator for the Medical Society, will handle all of the details, sending you the evaluation and materials for CE in the next day or so. Last week, we had the pleasure to hear from Professor Emeritus and UNM Regent Robert Schwartz, Representative Debbie Armstrong, and Nick Audio on the bill and the breakout of the law itself. If you were not able to join and want to watch, please send an email to info@nmms.org or note in the chat box that you would like last week's session. Thank you again for joining us today, and it's my pleasure to introduce our moderator, Barrick Wolf. Many of you already know Barrick, but to give you a little bit of background, Barrick is a mostly retired public health leader in New Mexico, working in rural primary care, EMS, and trauma systems, and was the director of public health division at the Department of Health. Barrick has served as an analyst for the Senate Health and Public Affairs Committee for the last 17 years. For the last 9 years, Barrick has been deeply involved with end-of-life issues and is on the founding board of directors for the newly created nonprofit End-of-Life Options New Mexico. Barrick, I hand it over to you. Thank you so much.
Well, thanks so much, Annie. You couldn't have said it better if I'd written it myself. It's an honor and a pleasure to facilitate this clinical overview of medical aid in dying and our new law here in New Mexico that goes into effect on June 18th. It's very exciting for those of us that have been involved for a good long time. Today, we'll hear perspectives from 4 clinicians and hopefully have some time, and I expect we will, at the end to respond to some questions or comments. We also have some legal expertise in the wings. As Annie said, Rob Schwartz is on the call and Debbie Armstrong is in the background watching us, and they're available as need be if some legal questions arise. So please feel free to use the chat for questions and during the talks, and we'll do our best to monitor that and respond as we can. The coalition that Annie referred to that worked for the last 5 years over 3 legislative sessions to authorize medical aid in dying here in New Mexico is in the process of forming a new nonprofit corporation, End of Life Options New Mexico. Our focus will be to support the implementation of the new law by providing public information, education, and personal support to patients and their families. We'll also be supporting healthcare entities develop their policies and by providing education and training for clinicians. This is not a one and done activity. This is for the long haul. We hope to and expect that will be an ongoing effort to support expert and compassionate care and accessible options for those with serious illness as their life approaches towards the end. We look forward to and appreciate greatly being able to partner with the Medical Society and many others as all of this moves forward. So our panelists for today, Dr. David Grube will start us off by sharing his decades of involvement with medical aid in dying in Oregon. Dr. Grube managed a rural family practice for more than 35 years and also found time to serve on and sometimes even chair the Oregon Medical Board. Dr. Grube is a national medical director for Compassion and Choices and travels extensively speaking and advising clinicians and policymakers. Dr. Judith Brillman is an emeritus professor of emergency medicine at UNM become involved in these end-of-life issues since her retirement from active clinical practice a couple of years back. She will speak about some of what she has been learning about medical aid in dying and the clinical resources available nationally to help our implementation efforts here in New Mexico. Nancy Gwynn, many of you know, is a palliative care physician at Presbyterian Healthcare Services, and she will share her efforts to help Presbyterian prepare their response to patients who request medical aid in dying. Dr. Gwynn's work also includes responsibility for advanced care planning, and was formerly the medical director for palliative care, hospice, and home health at Presbyterian. And lastly, Dr. Jonathan Bolton is director of UNM's Health Sciences Center, Institute of Ethics, and a professor of psychiatry at the School of Medicine. Dr. Bolton will raise some of the ethical issues that arise from this new end-of-life option. So Dr. Grube, with no further ado, please kick us off.
Well, thank you very much, Mr. Wolf, and thank you very much for the invitation to speak with you today about your new law. I'm coming to you from Oregon. As Mr. Wolf explained, I practiced for 35 years in a very small town in Oregon called Philomath, a town of about 2,000 when I started there in 1977, and I retired in 2012. Barack Obama, Atul Gawande said in his wonderful book, Being Mortal, that life is meaningful because it's a story. Our lives are meaningful because they are stories. And in stories, endings matter. And I think the Elizabeth Whitefield Act is about that. Individuals having the ability to write the last chapter in their life, if that's what they choose. My backstory is that early in my practice, I had a patient who was a neighbor and also a dear friend who developed a very aggressive kind of cancer and was in hospice and had excellent hospice care. But his symptoms, in particular, his bone metastasis pain, could not be managed. His son called me one day to come to the house, and my town's a little town, so I was able to go to the house and went into the bedroom, and Jerry, the fellow, was sitting in a chair, and he had a shotgun between his legs and had taken his life. It was, for me, the most traumatic moment of my long medical career. Very difficult to deal with. He was in hospice. I thought he was getting the care that he needed. And he did that. And I said to myself, when Oregon got our law originally in 1994, but ultimately in 1997, that I couldn't imagine a worse ending for someone's life. And I promised myself that I would always attempt to honor the wishes and values of terminally ill patients for whom I cared. So as I mentioned, our law actually went into effect in 1997. It was called the Death with Dignity Law, which is not a very good name. End of life options is a much better name. And I had a first request from a patient in 1999. If this was a typical person that would request this option, and let me kind of define them for you. They're usually elderly. They obviously have a terminal diagnosis and have been through the many different options of treatments, which have ultimately not been successful. They have a strong sense of what they want, highly educated, and this gentleman was a university professor who had a pancreatic cancer and had ultimately inability to be treated anymore. And so he requested aid in dying from me. While I knew that this was something that I would support and would help him, I did not know how to do that. And I think that's why we're here today, is to kind of talk through clinically what are the ways that we should respond. And I guess the first way is to learn about the law, learn about what the options are, and talk about it with our peers and our health systems and our hospices, so that we can be prepared when June 19th rolls around and New Mexicans might be able to request this option. So I sought help from the medical director of our local hospice, who was also an oncologist and who I knew quite well, and who I knew supported the Death with Dignity Act. And he met with me, and I asked him how, sort of step by step, how to go through the process. In Oregon, we have some forms that we must fill out and send in. I found those quite helpful for me to make sure that I crossed the T's and dotted the I's. I made sure that I was careful in understanding the request from this gentleman. And I asked him all the contextual questions and the important issues, such as notifying his next of kin, which by and large, these people do. This is not a sort of surprise thing. This is something they've thought about for a while as their disease has progressed. So we went through the process. This took, in this case, about 3.5 weeks. I offered to be with him at the time of his ingestion, which he declined. And in my experience, I've always offered in the cases that I had. Most people would prefer to be with their families, sometimes with the volunteers from the organization you're forming in New Mexico, your End of Life Options Coalition, and their hospice nurse. That's who they would really like to have. Well, at that time in 1999, the Oregon Hospice Association was opposed to aid in dying. They have subsequently reversed that decision, and now, as you know, as clinicians, not only is are many non-faith-based hospices supportive of choice, but the American Academy of Hospice and Palliative Medicine is also neutral, as are the American Nurses Association, American Academy of Family Physicians, et cetera. So a lot of things have changed since that day back in 1999, when I was asked to help this person. But a lot of things haven't changed too, and I want to talk about some of them. And in particular, as you, as a clinician, kind of face this question, things that you might want to be thinking about. I might finish that story about the professor, the university professor, by saying that until the pandemic occurred, I see his widow and family each Sunday at church, and regularly, at least annually, they thank me very much for helping her husband and their father not to suffer as he was at the end of his life. So to begin, it always matters to listen. When a person requests aid in dying, and more often than not, it is their request. I'll talk about other approaches in a little bit, but more often than not, this is patient-centered, patient-driven, and they request this of you. The most important thing, as we're doing today, is to be prepared, to understand the law. The worst thing that we could do, then, and in my opinion, an unprofessional thing to do, would be to say something such as, well, I don't know anything about our new law, and end the conversation there. That is really, I think, not only unkind and almost a form of abandonment, but we should be prepared, particularly those of us who have responsibility for individuals at the end of their life, to be able to converse in a good way about this topic. And more importantly, we should never dismiss the patient's request as something that they don't really know about and they don't really want. Again, I believe that that's unprofessional. We must open our minds to figure out why they're asking this. And when we have that conversation, that full conversation about all of their options and why they would or would not want one of these options, that is palliative. And I want to tell you, as a doctor who has had this experience, there is a relief. It's a big sigh of relief. There's a tension that is dismissed when an individual begins this conversation and you engage them. It increases the doctor-patient relationship, the trust, And it's so necessary to be prepared and to listen. As you have in your law in New Mexico, but we do not have in our law in Oregon, I'm sad to say, that this hospice option, where, as I understand it, if the individual is enrolled in hospice, that's essentially your second opinion. In Oregon, we don't have that. But I will tell you that in Oregon, since our Death with Dignity Act was passed more than 24 years now, our hospice enrollment is essentially the tops in the nation. And I know that New Mexico has a good hospice tradition, but it will be increased, I believe, as a consequence of these increased conversations, and in particular because your law is so well structured in that regard. In Oregon, we have about 95% of all of our death with dignity patients who are enrolled in hospice, 19 out of 20, and it seems to go up just a little bit every year from that. So that's a huge benefit for so many reasons, but in particular, when we have concerns about assessing capacity, for example, understanding if the patient really knows what they're asking for, and if they're able to make this decision, we have an assessment now by not only ourselves as good doctors, but also by the medical director of the hospice nurse, the social worker who does a great job in these capacity assessments, the chaplain, as this team looks at the individual, those people who do not have capacity, do not understand informed consent, can be understood and figured out, and so that worry that some individuals have about assessment of capacity is really diminished in the arena of hospice, and that's why I've always been a big proponent of hospice. I've been on our hospice board and chair of our hospice medical ethics for years, and there it just improves individuals, and then you'll find, I think, as we answer their issues, fewer of them will want to go through the process. And recall that in all of the states, and the 10 states that now have this bill, fully a third of people who go through the whole process and have the ability to have the prescription don't take it. Fully a third. It's quite fascinating. They just want to know, can they? Is it possible? Are they empowered? And when they have that assurance and that relief, they're palliated enough that they don't necessarily want to go any further. This is a team effort. It's very important to involve all members of the team, and in particular, the pharmacist. As we understood last week about the prescription, which I do want to make a little correction from last week. Generally, the prescription runs between $350 and $700 in most states now, so it's not as expensive as it was. But it is compounded, and so we need to have a conversation with the pharmacist. I had the experience, a difficult experience, of a woman who was in a Moby from her polio, but she was dying of metastatic breast cancer. She wanted to go to the pharmacy and get the prescription herself. It was a 4-mile trip, but she wanted to do it. Very determined, as I mentioned, this type of personality. She rode her Moby the whole way to the pharmacy. That day, the pharmacist on duty, only one in that pharmacy, was a faith-based pharmacist who would not fill the prescription that was sitting on the shelf. And so she had to write her Moby back the 4 miles and called the office, and we were able to help her get her prescription the next day when a more open pharmacist would dispense it. So it's imperative to talk with the pharmacist one-to-one and make sure that the prescription is available, ready, and can be dispensed when the patient wants to consider it. I also believe it's probably a good idea not to dispense the medicine until it's about to be taken, for many reasons, not only cost, but for security and safety as well. As Mr. Wolf explained, I have a history of working on the Oregon Medical Board. And in Oregon, we evaluate and review cases if there are problems with physicians and the law. And historically and traditionally, there has There are a few minor little issues, but no doctor in Oregon or any other state, to my knowledge, has ever been disciplined or lost their license for participating in an end-of-life option act. And also the value of the act, and Professor Schwartz delineated this last week, the value of the act is that it allows you to practice this and not be worried about being sued. If you go through the steps that New Mexico has, there is not really a risk for a litigation. I think a couple more things I want to mention before I share the panel, and I'm really excited to hear the other panelists. One is the death certificate. We write on the death certificate the disease that they were dying of: lung cancer, pancreatic cancer, or whatever. We don't put Elizabeth Whitefield End-of-Life Option Act on the death certificate. There are two purposes for the death certificate. One is for epidemiology, and that information about aid in dying is determined by your Department of Health and other forms. And the other is to establish the state. A death certificate is a public document, and really, in a sense, there's a violation, I think, of HIPAA, et cetera, to write that on the form, and we don't do that in Oregon or other states. If this is not something that you're able to support your patient in, it's imperative that you refer the patient in a timely fashion. These people are very sick, and many of them are dying quickly. That's why, again, your law is better than Oregon's, because you don't have that long waiting period like we do. But recall that when you refer the patient, you're not referring them for the Elizabeth Whitefield Act. You're referring them to another physician to discuss end-of-life options. No different than when a child comes in with abdominal pain, you don't refer to the surgeon for an appendectomy, you refer for assessment of the surgical abdomen. And then finally, Dr. Bolton last week brought up the great question, which I think we'll probably discuss a little bit more here today, about terminology. We aren't using the word suicide with the Elizabeth Whitefield Act, as we don't use the word in Oregon. First of all, non-clinically, but legally, as Professor Schwartz pointed out, it has been determined in New Mexico that this this option is not euthanasia, mercy killing, homicide, or suicide. That's the end of that statement. But furthermore, we understand what medical aid in dying is. We know it, it's defined. There's no confusion about the eligibility requirements, et cetera. But we need to use language in this, particularly in this arena, but in all arenas, that is kind, language that is not shaming, that doesn't cause guilt or harm, that's not pejorative. We need to use kind words. And many people can get upset, the dying family, the dying person and their family, when these words are used. And I think so often of a woman whose husband used medical aid in dying, a patient of mine, and when she went for her grief support group, everyone in the group said to her, "Oh, he's the one that who committed suicide with the Death with Dignity Act." And it was like a blade sticking in her heart to hear them have those judgmental thoughts. So very important to use language that's kind and that's appropriate. I've talked enough. I'm very happy to be here today, and I look forward to the other panelists, and also I will be very happy to answer any questions. Thank you.
You're muted.
Thank you. Thank you, Dr. Grube. And Judith, help us out. Take it away. Thank you.
Okay, thank you, Barak. And thanks to the New Mexico Medical Society for sponsoring this meeting. As an emergency physician, I saw intense suffering at the end of life. I dealt with countless patients and families at these trying times. After I retired, I became a hospice volunteer. These experiences have made me realize how important it is for people to be able to have some control at the end of their lives. As such, I am working with the End of Life Options New Mexico Implementation Committee to help bring the best practices to New Mexico. I'll now talk about this committee's activities. We are really here to serve. The committee is led by the indefatigable Nancy Abel. Literally, if you want to know anything about the clinical implementation of this act in New Mexico, ask Nancy. I'm going to ask Mr. Audio to do a screen share of some references, including Nancy Abel's email as I'm speaking. So Nancy has spearheaded an initiative which is connecting patients, hospices, pharmacists.
No, wrong one.
That's not the one. It's the one I have. It starts with Nancy Abel's email address. There you go. Thank you so much. Okay, so so Nancy has spearheaded an initiative which is connecting patients, hospices, pharmacists, and providers in New Mexico. For instance, a terminally ill patient contacted End of Life New Mexico requesting help accessing medical aid in dying. We contacted him and suggested he ask his hospice. His hospice agreed, and we provided information to the hospice personnel and identified a local pharmacy willing to compound the meds. Medical aid in dying is practiced in 9 other states and DC. There is a wealth of institutional knowledge. We are connecting New Mexico practitioners with resources nationwide. In addition to compassion and choices, an extraordinary amount of clinical information is available from the American Clinicians Academy on Medical Aid in Dying, ACAMAID. This includes videos for prescribing, counseling, drug administration, etc. ACAMAID was also mentioned last week. This website, as well as the dates of times of activities I'll now describe, are on your screen share. If you'd like this document emailed to you, please put your email in the chat box. I'm now going to describe some of the resources and events available for New Mexico providers. Dates and contact information are on the screen share. All of these events are open to anyone who wants to participate. I didn't want to put the links publicly, but email Nancy or me for those links. So Nancy has arranged for New Mexico physicians to ask questions of Lonnie Shavelson, who has the most experience in the US of prescribing aid in dying medications. The New Mexico physician participants have already accessed clinical training on the ACAMAID website. So because of the clinical training on the ACAMAID website, they didn't feel that they needed basic training from Dr. Shavelson. They just felt that they needed to ask questions. So physicians are welcome to join into this, or other providers. Nancy has also identified New Mexico pharmacies willing to dispense these medications. She has arranged for New Mexico pharmacists to receive training from a compounding California pharmacist. There's a listserv through ACAMAID for providers throughout the US where participants can exchange ideas. These providers have a bi-monthly Zoom meeting. The July meeting is a forum for New Mexico providers to discuss medical aid in dying processes with their peers. An additional update is that Representative Armstrong and Professor Schwartz have been meeting with the Office of the Medical Investigator. They are working with the OMI so that it can determine which deaths are attributable to medical aid in dying. They are working on a draft patient request for aid in dying medications and on a reporting system to the Department of Health. For more details of this, Professor Schwartz is on the call and he can respond. In sum, we are working on a lot of fronts. Truly ask, if we can't help, we will find someone who can. Thank you.
Okay, now we'll, if we can go back to the full screen, we'll shift over to Nancy Gwynn.
Hi there. It's great to see so many friends and colleagues on this. I've been looking through all the screens and recognizing so many people. I'm Nancy Gwynn. I'm a palliative care and family physician, and I work at Presbyterian Healthcare. I'm just going to review the efforts at Presbyterian that we've been making to address the law. Nick, I don't think you need to screen share the specific documents I'm referencing. I'll just mention that they'll be available and how to access them through New Mexico Medical Society afterwards. First of all, boy, have we had a lot of meetings, more than weekly probably since the law was passed, like everybody else. And our approach to, the goal was to come up with an approach to the law that was solid and collaborative and consensual throughout the healthcare system. I think that was really critical to us. A key feature for us is threading the needle to assure that we honor our patients' rights to discuss all end-of-life options in balance with acknowledging that all of our providers, clinicians, and staff at Presbyterian have the right to opt in, to participate, and to prescribe, and have the right to opt out. And so how do we assure that patients receive the information that is appropriate and indicated under the law has been, and yet allow people to opt out has been something we've been parsing quite a bit. We also felt it was important to acknowledge that all of our clinicians and staff may get asked about this in ways we're not even thinking of. In other words, it's easy to identify that the people you really need to focus on are, quote, the prescribers or but you know, if you work at Presbyterian, your next door neighbor may be asking you what you think, or it could be someone in the grocery store. We also anticipate nurses walking or techs walking down the hall in the hallway being grabbed by a family member saying, hey, I need you to talk to my family member about medical aid in dying. So we're working on informing everyone about the law. Our communication and education department, I just finished meeting with them before this. They've been very involved. We're setting up internal web pages that actually have information and are even crafting videos to help people understand the best way to respectfully refer someone who might ask them for information if they themselves are not able to give the appropriate information about or inquire of the patient effectively what's going on. And of course, I'm attending a lot of clinical meetings throughout the health system to discuss it with as many clinician groups as I can. So we have created 3 pieces of materials so far, which we're sharing with the medical community. That material so far is a provider-facing informational leaflet, a patient-facing informational leaflet, and the latest is an approach or a guide to in-depth conversations with patients who inquire about medical aid in dying that we have built together with the palliative care physician group at Presbyterian with some references to a couple of national pieces. All of those I've made available to both the End-of-Life Options New Mexico group as well as the New Mexico Medical Society in the hopes of sharing them. I think our goal is to develop basically shared communications and a shared standard of care throughout the state by being able to reference similar material. So maybe you can look at that as a template or a baseline for some of your approaches to medical aid in dying. The patient-facing one is still very legal and very not very patient-friendly. Our internal communications department, I've asked them to attempt to assist with that, and then we'll republish that. But at least there's something there that's an explanation. We're also created a team of people at Presbyterian who volunteered to educate themselves on the law extensively. We're starting our little group training sessions and study sessions, and they have volunteered to serve as a resource to all of their colleagues at Presbyterian who might have questions. And the questions aren't just how to prescribe. The questions are, a patient asked me this, or I don't know how to approach this. Maybe the question is, I don't know how to opt out, and it's critical to me that I do because of my right of conscience. How do we steer them in an appropriate way to do whatever it is that they are feeling strongly about? So that group is going to be available. There are quite a few clinicians, quite a few people from different areas of Presbyterian, and we're going to make ourselves just available to our colleagues in the hopes that that will help. We're also encouraging anyone who decides decides that they do want to prescribe, that they consult with us prior to the first time they do that, so that we can really, as Dr. Grube said, really clarify exactly the best documentation and most effective approach. And we are completing documentation. We're building notes in our medical record and guidelines, so that if someone has these conversations, and particularly if they choose to prescribe, that they're in compliance with all of the requirements of the law when they do so. My personal focus is on the conversation, and that's what's most critical to me. And I'm working hard to ensure that when patients with a terminal illness are treated, that they receive the care they deserve, to explore all aspects of their symptoms and support during that illness, and the suffering that they often express is really well addressed. I'm hopeful that by opening up the topic of medical aid in dying in New Mexico, we will also have an opportunity to expand access to palliative care and to those critical conversations.
Great, thank you, Nancy. And again, we will look forward to posting those documents, I guess, the Medical Society, and also on our website, endoflifeoptionsnm.org. And again, we'll make that information available. And certainly, last but not least, we're all going to get a perspective that's a little bit different from Dr. Bolton. Thank you for joining us.
Thank you, Barak. We don't have a lot of time to really explore the ethical issues, for obvious reasons today, associated with the End of Life Options Act. The UNM HSC Institute of Ethics is going to be presenting a series of discussions on some of these issues, including the concept of rational suicide and conscientious objection and physician-assisted suicide for non-terminal conditions. So we'll have other opportunities to talk through some of the ethical issues. So today I wanted to sort of just take you along the trip that I've made in trying, as a clinician, trying to think about this, the statute and also the practice. And I think before we can get into the ethical aspects, we have to really understand what the statute is and what it does. And I'm not going to focus on some of the practical or political consequences, but more on the ethical dimensions. And I think, again, following Dr. Grube, we do have to have some sort of sensitivity to definitions and to words. And I'm going to be talking more today as an ethicist than a clinician. And I probably would change my words in clinical settings. But I think that, to my mind, the Elizabeth Whitefield End of Life Options Act is a statute that legalizes physician-assisted suicide. And I'll defend why I'm using the word suicide in a second. I'm completely sensitive to the intention to spare families from the stigma of suicide and to compound the distress and the pain that is associated with the death. So that, I think, is an absolutely valid point. But I think, to be a little semantically persnickety, the two terms of suicide and dying are not equivalent. Dying is a passive process or an event, whereas suicide is an action. And this is controversial because it is an action, because the statute refers to an action. And I also believe that it's a good time to try to reclaim the term suicide from its Augustinian proscription that we've been living under for so long, and to essentially rehabilitate it and to allow the possibility of a rational suicide. So, for those reasons, I do, at least in analytic sense, want to preserve that. The last semantic issue I would raise or put on the table is that it is not treatment in the usual sense of reducing symptoms or treating a disease. It's an intervention, but it's not a treatment. And so when we use, and I think the statute uses the word medications and that sort of thing, that we probably should try to avoid that for a sense of clarity. The big question will be, can the intervention, if it's not treatment, be congruent with healthcare, with caring healthcare, and I will argue it can be. So it may be a semantic distinction only. But so what does the statute do? I'm getting on thin ice for me because I'm going to make a legal or juridical argument here, but I'm going to say that the statute first reaffirms an existing right, a privilege right, and creates a new right for individuals who fit the inclusion criteria that we've been talking about. So the existing right it's a privilege right. It has not been illegal to commit suicide since the 1960s. So there is a liberty right to kill oneself, assuming there's no contradictory right against doing so or no disqualifying conditions like lack of competency. And I think this statute usefully restates that right to end one's life and introduces the option of doing it with medical assistance. And I think that's not the difficult part. The other thing that the statute does, and far more significant, is that it creates a claim right, or a right to make a claim on prescribing healthcare providers. And when the provider accepts the claim made by the patient or by the person, they incur an obligation, a new obligation and an additional obligation. And this is actually fairly unusual in medicine. There aren't a lot of situations where claim rights can be asserted from outside the profession, like from the legislature. And this actually might be one source of resistance amongst physicians. I'm not justifying, I'm just saying that they may see this assertion of a claim right as something, and they may react to it emotionally. The third thing that the statute does is that it recognizes an immunity to the claim rights in the form of conscientious objection. So the claim for assistance that's made by a patient may be rejected by a provider if that provider thinks it would violate moral or religious or professional beliefs or obligations. But as we know, it's not an absolute immunity, because the law requires that the provider, and moral sort of morality requires it too, requires the provider to either transfer the case or to refer to the group that Barack mentioned. Some might feel that this constitutes complicity, and that would be something to talk through. So the question, so we have medical aid in dying. It's a legal right. Is it ethically right? That's the discussion. Now, the End-of-Life Options Act refers to a very narrowly defined circumstance of terminally ill patients with a prognosis of less than 6 months who are competent to make the request. So these limitations actually make it a lot easier to defend on moral grounds than, say, other practices like other forms of physician-assisted suicide for non-terminal conditions or euthanasia. So support of this statute does not necessarily imply support for those other practices. So the law asserts a legal right, the privilege right to end one's life. Obviously, that's been discussed for millennia, ever since Socrates, and we're not going to go into that today. But the case for ending one's life during an unremitting and inevitably terminal illness is not a very difficult argument to make. I think as clinicians, if we have seen it, or as family members, it's not a very difficult argument to make. It allows the person to avoid further deterioration of functioning, loss of self-control, indignity, alterations of consciousness. So the decision of whether or not to end one's life is properly made by the individual. And I'm not personally warned off by slippery slope arguments, or I think that this could be a good thing and a right thing to do, and for fear, and not to be avoided for fear that we might end up with, full-on euthanasia. I think we're able to monitor those steps and interrupt them as they occur, or to prevent them from occurring. So I think that the statute justifiably reaffirms this privilege right to end one's life. The stronger and more morally difficult part of the statute is this assertion of a claim right on the prescribing clinician to provide the means by which the individual may choose to end his or her life. And clinicians generally, and physicians in particular, have a variety of legally supported immunities against claims that are not congruent with their professional values or practices or their personal values. And we usually use the word conscientious objection to refer to the personal values, but it doesn't necessarily have to be that way. So the ethical question is whether the claim for assistance that a patient will make of us, whether it is congruent with medical values and practices. So we've established that physician-assisted suicide is not medical treatment, it is an intervention. Yeah. If you believe that the end or the goal of medicine is to treat disease, then you might conclude that, that this practice is not justifiable. It's not justifiable medical practice. However, if you consider that the reduction of suffering from disease is part of the medical practice, is part of what our good is, then you might conclude that it is justified. And I personally believe that the terminal good of medical care or healthcare is the reduction of suffering, and treating disease or controlling symptoms is only an intermediate goal. Lastly, it's congruent, I believe, because medicine values compassion and the dignity of the person, and both of these values are congruent with physician-assisted suicide or medical aid in dying. And so for these reasons personally, and not speaking for UNM, but personally, I support the privilege right to end one's life. And also I support the acceptance by clinicians of this claim right. And so by extension, I would also support the healthcare systems taking on and recognizing this obligation. So, so ultimately, I believe that it's ethically justified.
Dr. Bolton, as advertised, thank you for laying out these sort of philosophic dilemmas that we find ourselves in. And I think a number of us will look forward to engaging with you further as you have these conversations about these aspects of our new law. I know, you know, others will have a different view perhaps, and that's as it should be. With that, let's open up to a conversation or comments. In the chat room, you can identify a question. And if I see a hand, although there's quite a few still on, so it's hard to see everybody, we can call upon them. Did I see a hand from Jennifer there? Did you have a question or not? Okay.
No, just scratching my forehead, but glad to see everyone.
Okay, very good. You fooled me. Any others pop to mind, or is there anything in the chat that we ought to be covering? Or perhaps Dr. Grube or Rob Schwartz might want to engage a little further with Dr. Bolton, but I'd rather get to questions or concerns from clinicians who are hearing this perhaps for the first time, rather than pursue the philosophical aspects.
I have a question for Dr. Grube. Hey, Dave. What, you know, we have been looking at, of course, at the California American Clinicians Academy website quite a bit for drivers on prescriptions, pharmacy, all the information you're aware that's there. Is there any other location for clinical care that's publicly accessible that we could also be looking to? I've been searching for another equivalent site.
Yeah, thank you. That's a very good question. Yes, Compassion and Choices also has on our website a lot of information. And I personally made quite a number of YouTubes that you can look at, although they are not specific to New Mexico, and some of them may be a few years old. The core components of responding to a patient request should be there. And then finally, we have the doc to doc line. And so Compassionate Choices has this line. It's free and any physician can call the Compassionate Choices number, which I can tell you is 1-800-247-7421. And a physician will be available to talk through, mentor, or respond or answer questions. Generally live, but sometimes certainly within less than 24 hours. So those are some other resources.
Thanks.
What is that number? I want to put it in the chat.
Sure. I could do it too. It's 1-800-247-7421. And that's the doc to doc line.
And I'll go through the Compassionate Choices website and update the reference materials that I've already just sent out again, but you know, we'll keep updating to make sure that those references are available too. You know.
Zumu asked a question in the chat about the role of hospice and all of that. I'll take a quick answer, and Dr. Grube or others may have a little more experience with it. As all healthcare entities, a hospice or a hospital can choose to opt out of providing this. As they opt out, they have some responsibilities to that patient to discuss end-of-life options generally, and also then to make a referral either to a clinician who can help them, or even to a helping organization like ours that can help guide them in the right direction towards the resources they're seeking. The experience, I think, so far is certainly there are certain hospices, particularly those that are religious-based, that will opt out, unquestionably. There are others that are going to sort of take a wait and see attitude and not jump into this too quickly and get the experience. And my sense is, from a recent exchange on the Acamade listserv, that the participation, the active participation by hospice grows over time in given states. And Dr. Grube, maybe you'd speak to that, because Oregon's been going the longest.
Yeah, that's absolutely true. And I've observed the different states as they've come on. And California hospices, originally very hands-offish, and now have moved to be quite engaged. And then Colorado and Washington also, DC, Hawaii, and each state that comes on, New Mexico now, comes on in a much further place along the road. As I mentioned, hospices in Oregon historically 100% were opposed to this option back in 1997, and currently now pretty much are not opposed, as is the Hospice Association itself. They take a neutral position, and there's varying degrees of neutrality, from studied, which means we'll support your request, to engage, which means we'll help you more than just support, all the way from allowing a nurse to be present, allowing the medical director to prescribe, varying degrees and varying policies. But there is a movement much more toward engagement than there was.
And just to tie that off, I think there's also, it's not either in or out. For those who are wishing to participate, individual hospices will describe their policies and what they allow their clinicians to do, their volunteers to do. So there's a range within each of the possibilities for how a hospice will participate over time. Dr. Gallant, do you have your hand up?
Yeah, I do. Just a couple of quick points. One is to maybe think differently from Dr. Bolton, in the sense that many of the interventions we do are not going to cure a disease. And so treatment itself can be palliative. It can reduce pain or suffering, and that is a treatment. So for instance, when we give a pain medication, we have not changed the process of the pain generating event. A broken leg is a broken leg. The morphine and the ED didn't change that, and it is it absolutely is part of the appropriate treatment of that patient. So you made the point that this was not a treatment because it didn't produce some sort of cure, but I would differ with that definition. So that's just one quick point. The other is, I appreciate you bringing up the definition and the verbiage around whether or not we say assisted suicide versus medical aid in dying. I thought Representative Armstrong did a great job of sort of defining the alternate view about why we would choose a word like medical aid in dying versus suicide. And I think that this is likely to play out over some time. I mean, this isn't just settled because the law, uses the terminology that many of us prefer. I think it's very important for us to listen to what you're saying so that we can understand a different point of view, but then also, make our point, as I thought Representative Armstrong did exceedingly well, I think it was last week, in defining the differences in the way that we see those terms, because there is so much baggage with suicide. It carries a whole, backpack of rocks of moral and ethical conundrum with it. And so that's why I kind of take that alternate view, but I appreciate you making the point. Thank you.
We got a few more minutes if there's another question or comment.
Barrick,
Please, Nancy.
I think somebody asked in the chat, how does a patient find a doctor who's willing to prescribe? Is that person here?
Well, you could answer the question for the
Yeah.
group.
Okay,
I can tell who it is by the connection. So it is, she's asking actually, Dr. Sansonetti, I'm gonna, it's clear from the sign on who that must be. But what she's actually asking is how will the committee, what's exactly the process around how a patient would reach out and how the committee would help? I think that's what I'm seeing.
okay, so the question for me would be if the patient asks his or her own provider, either primary care doctor or specialist, and those people say no, that to me would be the issue, because if they say yes, you don't need another process. And so we at End of Life Options New Mexico are here to be a referral source, a referral hub for patients like that, and you can contact us through our website, but we will ask that you have already asked your primary care and your specialist first. But if the answer is no, then we will try to connect you. We do have a group of providers who are volunteering to help not only their own patients, but patients whose own providers either cannot because they work for the VA or the Indian Health Service or other organizations that are federally funded, et cetera, or providers whose conscience won't allow them to participate.
I see a parsing in this question that I'm going to ask if I could address, Nancy.
Go ahead.
And that is also about the law, because what if you've had a very in-depth conversation with a palliative care provider who's checked all the boxes? This is a voluntary act, we've received a written request, but that person chooses not to prescribe. How much is a start over? And when I think about the law, and I'm curious whether our legal representatives would agree, I believe the prescriber needs to go through all of the checklist again. So the medical documentation from a prescriber or from a physician who has a clear conversation with a patient could support some key tenets: the terminal prognosis, the decisional capacity, and the ability to self-administer. But if that person is not the prescriber, that's all that would transfer. And the prescriber themselves under our law would need to go through all of the other criteria. Rob, you're off mute, so I think you would agree, right?
Yeah, I mean, without doubt, the prescriber has to make those findings, but the prescriber in making those findings can depend upon all the information, can depend in part upon all the information in the medical record. So in fact, the findings that other physicians have made or that other healthcare providers have made would be relevant to the prescriber when the prescriber makes those determinations. That will make, I think, the examination that's required, which is just a reasonable examination under the circumstances, a much easier burden on the second prescriber when that person is depending upon dependable findings made by a colleague. So that it's not the work that has been done by the provider who is opting out is not irrelevant, but the actual prescriber must make those findings as well. Again, in part probably based upon the determinations of other physicians or providers.
Okay,
I think there's oh, sorry, Nancy, I didn't mean to stop you.
That's okay. I just want to finish the process. Because we're getting to 12:59 and some people may have to leave. If the patient has asked two providers known to them and both of them say no, and whether or not they document all of those wonderful things that Nancy said, or they do not, in either case, End of Life Options New Mexico will attempt to connect the patient with a willing provider, but that list is confidential. And we will not share it with the referring provider. We will not share it with the patient. We will go to our list and we will say, would one of you be willing to see this patient? And if we get an okay, then there will be a connection made. So I think that's a question that patients ask. They will be asking us and they will be asking you. And I'm happy to have a further conversation with anybody who wants more clarification. Barrett.
Just in winding down, I just want to be clear that our new nonprofit, End of Life Options New Mexico, is just gearing up to be helpful to all of you who do the real work. We have a lot of work to do ourselves, to position ourselves, to develop our policies, to get our website up and going. And this is just sort of an opening overview today. And I'm so thankful to Annie and to all of you for participating. We all have a lot to learn. This is going to evolve as it has in Oregon for 20 years and other places. This is not a static process. And we'll look forward to working with you and getting this done for the seriously ill and dying patients of New Mexico. It's a law filled with compassion. Annie or Dr. Grube, or a final moment? No, okay. Annie, anything to wrap it up?
No, thank you all. This was a fantastic series. We really appreciate being able to work with you and to provide this to clinicians across the state. This will not be the last one. It's
No.
an ongoing issue. Dr. Gallant, do you have something?
Muted.
You're muted.
Just wonderful to see all of the faces here. And, I think that a critical thing that we've tried to value, I heard it from Nancy, and we at the Medical Society have said the same thing, is autonomy and education. We think both of those are critical. We are not expecting every Medical Society member to do this or to support this. We respect their choice and their own moral compass, but we also want to provide a great conversation like which took place today, provide information, and I thank all the speakers for being here today. And I think that's a great service the Medical Society and your organizations have provided for the medical community. So this is a good day for medicine, and leave it there. Thank you all for being here.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thanks, everyone.
Thank you all.